Thank you.
طيب, my presentation is gonna be like an interactive session. So we are gonna talk about the case faced during our clinical practice. And I think our colleague in the previous lecture made everything easy for us. Okay, so let's start. So I will start with we have nothing to disclose. And this is my outline. So we'll start with a few slides of introduction, then we'll start with the case discussion and how we apply the guidelines in this case. So as everybody know that we have a variety of the interstitial lung disease, and this interstitial lung disease can vary based on the geographic distribution or based on the gender and the age of the patients. And the most studied type of ILD is the IPF. And we have to know that some of these ILD patients, usually they progress over the time. And this is why we have now what is called progressive pulmonary fibrosis. So I think everyone knows this slide or this diagram and how we can classify the ILD. And usually we use this diagram to approach our patient in the ILD. I will not go through it. Also, already my colleagues went through it. So let's start with the case presentation with no delay. So my patient is a 74-year-old gentleman, former smoker, presented to my clinic with a shortness of breath and cough for 8 months. He has no chest pain and no orthopnea or PND. He has no constitutional symptoms. There is no history of occupational and drug-induced lung toxicity. He has no symptoms suggestive of connective tissue disorder. So going through the past medical history, he has hypertension, diabetes, hypothyroidism, and GERD. Past surgical history is significant for appendectomy. And the family history, his father died from heart disease at age of 84. Socially, he quit smoking 15 years ago with the history of 1 pack per day. He is retired and he was a teacher. Vitally, when he presented to the clinic, almost stable, oxygen saturation 92% on room air. He has a finger clubbing. Chest exam showed basal crepitation with a normal cardiovascular exam and the other examination as well. Lab work. As our colleague advised, we did our lab work, including the basic and the serology. For the basic CBC and renal and liver profile were normal. Serology were negative for ANA, anti-CCB, and rheumatoid factor. So this is the main basic usually we ordered. So because the patient has a chronic progressive shortness of breath and crepitation or signs of interstitial lung disease, and the exam, we did the chest X-ray. So just we need your help to interpret what we have in this chest X-ray. Anyone? عادي هو sessions friendly sessions زي ما يقولوا. We can say anything. طب do you تفضل دكتورة. Okay, excellent. So we have increased reticulation bilaterally. Okay, what else? Shaggy hair border, okay. We can agree on that. What else? So let's say if we're thinking about the interstitial lung disease and based on the age and based on the symptoms so far and the serology that has been negative and negative history for connective tissue disorder, we think now about usually IPF. But do you think that patients with the IPF having normal lung volume? So there is no losing of lung volume in this patient. What do you think? What happened? Okay, let's just proceed and see. This is the BFT. So can we pointer here? Do you have pointer here? Okay, just if you see here, for vital capacity, 67%, AV1 72 ratio is normal. Goes likely with the restrictive pattern, but we have to see the total lung capacity. Total lung capacity here is 64%, so it's reduced with the reduced RV. DLCO here is 41%. We did a 6-minute walk test for this patient. The patient has significant desaturation on walking down to 84%. So what do you think from what we have so far? What should we do next? High resolution. For sure, we'll do high resolution CT. Okay, in addition to the high resolution CT, echo, why? Pulmonary, looking for what? Pulmonary hypertension. Is there any clue here say that there is a pulmonary hypertension? Yes, excellent. Yes, this is urge us to do echocardiogram because there is out of proportion reduction in the DLCO comparing to the vital capacity. This is why we think about the pulmonary hypertension, okay? The second things here, if you see what we have in this patient, so the lung volumes is abnormal, but in the upper abnormal range. So, or we can say little bit below the normal range here. So we did echocardiogram, right ventricular systolic pressure is around 55, so it's high. So what's next? Already the doctor said we'll do CT scan. So this is the cut of the CT scan that we have. So just only we have few cuts. So any volunteer or you want me to go through it or it's up to you? طيب واضحة السي تي ولا شوية عشان يمكن اللايت؟ طيب so what we have, I will talk about the LD finding here, then we'll go back why the patient has a normal lung, normal lung expansion in the X-ray, let's say. It's not normal, but near to normal, let's say. So we have like subpleural reticulations, we have some traction bronchiectasis in some area, and we have some area of the bronchiectasis and area of honeycombing. So this is usually goes with the UIP pattern. I don't have the whole cut, to be honest with you, to present everything. But the other things that is very important here, also if you notice here, there is no much losing of lung volume in these patients. And this is because the patient has something in the upper lung. What is it? So the patient has emphysema. So the scenario now is typical with which diagnosis? Is a combined disorder. So this is the typical with the severe or moderate to severe pulmonary hypertension in those patients. So we have to pay attention to this entity if we consider it one entity, because some physicians say that this is not one entity, this is a different entity. But if we consider it, we have to pay attention because it's associated with the high mortality. So what's the diagnosis? Is a combined pulmonary fibrosis and emphysema. So I believe that our colleague went through this algorithm, and this is what we did in our presentation, in our case. We did a detailed and comprehensive history and physical examination that followed by some serology tests, and based on what we have, we did a CT scan to see if the patient had UIB or probable UIB, and after MDD, we can say this is IPF or there is alternative diagnosis. So just one slide about the combined pulmonary fibrosis and emphysema, because IPF is common in those patients with history of smoking. Also, those patients may present with the emphysema. So sometimes subnormal or near to normal PFT doesn't exclude this high or progressed disease or severe disease in those patients. So we have to collect all the information together to make our decisions. So those patients usually they have heavy smoker history, they have hypoxia mainly on walking, and upper lobe emphysema with the lower lobe fibrosis. there is unexpected subnormal lung volume and severe reduction to the DLCO. Usually, high-resolution CT can diagnose the entity. Okay, in different way of presentations, I think Dr. Mohammed Al-Ghamdi presenting most of these studies, and these studies just say what has been approved as a medication for IPF, including the perfenadone and nintedanib. Sorry, I think there is a movement in the highlight after changing the slide, but we are talking mainly here. The only medication that has been approved is perfenadone and nintedanib for IPF. What about those patients with the combined fibrosis and lung emphysema? So still, we don't have a good evidence to start these antifibrotic. But if we consider this as two disorder, we'll treat those patients as IPF and treat them as COPD as well. Okay, but we have what is called sub-analysis on those population or some of those population patients in the IMPULSES trial and showing that the effect of or the impact of presence of emphysema in the effect of the nintedanib. So starting nintedanib in those patients with the no emphysema from the beginning has the same effect if we started on those patients with the emphysema at the beginning. So we believe that we need to start emphysema nintedanib in those patients. Right. Back to our patients. Okay, we started nintedanib for these patients. Unfortunately, the patient came back again to my clinic and say, I hate these medications. It's causing frequent diarrhea. I cannot stay in my room just for 2 hours. So the patient complaining of frequent diarrhea, but has no vomiting or weight loss, no constitutional symptoms, and lab showing there is no signs of infection, normal CBC, renal profile, and liver profile. So what should we do for these patients? I mean, this is the real scenario. This is a side effect of the medications. So what's the manufacturer said about this side effect? They say that 95% of the patients, they have mild to moderate diarrhea in intensity, but only 5% of all patients discontinue the treatment. And the majority of treatment usually, the diarrhea occurred in the first 3 months. What should we do? Before starting the treatment, we have to educate our patients about this complication because it's not a simple complication. Because the patient sometimes discontinue the treatment because of this. So we don't want to do, we don't want to have interruptions in the treatment. This is why we have to educate the patient before starting the treatment. And this is a message, very important message to all pulmonologists, for us as well, and for the family physician and general practitioner. And we have to tell the patient there is a possibility of diarrhea, nausea, and vomiting. And they have to modify their diet as well, that any factor that increase the diarrhea should avoided or discontinued. The other things, what should we do? We have to ask the patient to be hydrated during the diarrhea, and the patient needs admission, we will admit the patient. If the patient need anti-diarrhea medication, we will consider it, and also antiemetic medication. Sometimes the nausea vomiting reduced by giving the patient medication in between the meals or during taking the meals. If the patient couldn't tolerate it, we can reduce the dose from 150 to 100. But if still continuous, at that time, we have to consider discontinuation and shifting the patient to the other medications. Okay, good. The good things for this patient, I mean, we managed his diarrhea and he is satisfied, but he came back again after 3 months. I think this time he complained of non-specific upper abdominal pain and he's very upset. Okay, you give me a medication that's causing a lot of side effects for me. So one of the fault that we did, maybe we didn't educate the patient that these are the side effects, and we have to do this in all visits, and the the time of initiating the treatment. The patient complain of non-specific abdominal pain, no jaundice, no change in the bowel habit. What should we do now? طب سو LFTs. Okay, we have to do LFTs. Why? So this is by manufacturers that we have to do a baseline LFTs repeated every month for 3 months, then repeated every 3 months. So to detect any abnormality in the BFT, because this is a known side effect of the medications. We have to educate the patient if he has any pain, jaundice, or dark or brown urine, you have to seek medical advice. So what should we do if we have increasing the liver enzyme? It depends on the level of the increasing liver enzyme. If the patient, if the ALT or AST up to triple to the fifth of 5 times upper limit of normal and no sign, we can reduce the dose or do interruptions. Or if the patient has more than 5 times, we have to discontinue the treatment. So unfortunately, we discontinued the treatment for this patient and we shift the patient to pirfenidone. So the second things or the important teaching point here that we have another medication as well. In addition to the nintedanib, we have pirfenidone. So don't forget pirfenidone or don't forget nintedanib if you start the patient on pirfenidone. And we can switch from this medication to the another medication. And these are the common side effects for pirfenidone and nintedanib that we have to educate our patient about it. So initially, with the first visit, once we decide about the treatment, we have to make a mutual acceptable decision between us and the patient. We have to share the patient in our plan. So we have to discuss the efficacy and safety of the medications, about the FDA approval of both medications, what's the side effect of these both medications, about the symptoms and the management of comorbidities, and what's the expectation. This is a common slide that I put it in every presentation that I do. So sometimes, as a physician, we prefer to start nintedanib, and sometimes we prefer to start pirfenidone based on the basic of the patient. So some patient loves the suntan. So because pirfenidone causing complication or skin photosensitivity, we start nintedanib. Sometimes the patient say that I'm hating the diarrhea. I don't want diarrhea. So we'll start with the pirfenidone. And this is, I will conclude with this slide showing how it's important to manage the patient of IPF from all aspects. This is a holistic approach in the management of the patient with the IPF, because we don't want to say only management is antifibrotic. We have to manage other aspects, including the need of oxygen, including the symptom management, including the risk factors, including the most important things that usually we miss, the psychological aspect of the patients. And thank you.